Okay, macrocytic anemia. We know that anemia can be divided based on the mean corpuscular volume of the red blood cells, and in macrocytic anemia, that value is going to be above 100 centiliters. Of course, we also have the definition of anemia itself, which is a hemoglobin value less than 12 grams per deciliter in females or less than 13.5 grams per deciliter in males. So, macrocytic anemia can be further divided into megaloblastic and non-megaloblastic anemia. Megaloblastic meaning we have a problem in DNA synthesis and repair, whereas non-megaloblastic anemia does not have DNA replication problems. Instead, there's a problem with the red blood cell membrane due to problems in cholesterol metabolism. Under megaloblastic, we have the ones that are more typical, like vitamin B12 deficiency and folate deficiency, while non-megaloblastic can have several causes including chronic alcohol use, liver disease, hypothyroidism, myelodysplastic syndromes, and sometimes hemolysis and hemorrhage. Vitamin B12 deficiency can be due to several causes, including pernicious anemia, where antibodies are produced against the parietal cells in the stomach or even against intrinsic factor, and since vitamin B12 needs to be bound to intrinsic factor for proper absorption, you can end up with a vitamin B12 deficiency. Another cause is atrophic gastritis. You can also get vitamin B12 deficiency in malabsorption syndromes like in Whipple's disease or small bowel bacterial overgrowth. And also, since vitamin B12 is absorbed in the ileum, you can also have vitamin B12 deficiency due to Crohn's disease. Vegans may also be at risk of vitamin B12 deficiency, as animal products including eggs and dairy contain vitamin B12, and therefore they may need to take extra supplements. Folate deficiency mostly comes from a diet deficient in fruits and vegetables, but can also be caused by malabsorption, such as in Crohn's and celiac disease. It can also be caused by an increase in demand. The biggest one is pregnancy, and this is due to the folate catabolism that occurs. Congestive heart failure and liver disease can also lead to an increased demand due to the release of folate from the damaged cells. Finally, there are some anti-folate drugs such as methotrexate, sulfur drugs, or anti-seizure medication like phenytoin and barbiturates. Alcohol may also interfere with folate metabolism. The important difference between the two is that it takes a long time to become deficient in vitamin B12 because the stores can last for years. However, folate stores, on the other hand, can run out in just a few weeks. In terms of the clinical features that can be seen, they include the general features of anemia, which include pallor, fatigue and weakness, dyspnea, headaches, and dizziness. But you can also have neurological symptoms in vitamin B12 deficiency, because vitamin B12 is important in the synthesis of myelin. Therefore, you can have patients with numbness, tingling, loss of vision, as well as dementia-like symptoms from vitamin B12 deficiency, including loss of memory. Diagnosis generally involves looking at the complete blood count as usual, looking for hemoglobin, as well as the mean corpuscular volumes. This would then allow us to establish the presence of anemia as well as to classify the anemia based on the MCV. Peripheral blood smear may show hypersegmented neutrophils, meaning neutrophils with nuclei with more than 6 lobes. This is a finding that is nearly pathognomonic for megaloblastic anemia. While in non-megaloblastic anemia, podocytes are often seen, which are also known as target cells. These have a central collection of hemoglobin surrounded by an area of pallor, which itself is surrounded by another collection of hemoglobin around the outside, giving it a target-like appearance. When diagnosing vitamin B12 deficiency, vitamin B12 levels, of course, would be checked. The usual values are between 200 and 1000 nanograms per milliliter, with borderline values being 100 to 200 nanograms per milliliter. Homocysteine values may also be checked, due to vitamin B12 acting as a cofactor in the conversion of homocysteine into methionine. Therefore, homocysteine levels may be increased. The normal range is usually 4 to 15 micromoles per liter. Finding the cause of the vitamin B12 or folate deficiency may involve testing for anti-intrinsic factor or anti-parietal cell antibodies, as well as a possible esophagogastroduodenoscopy with biopsy of the gastric mucosa looking for atrophic gastritis. The biopsy would show atrophy of all layers, loss of the glandular elements, and an inflammatory infiltrate, as well as the absence of the parietal and gastric chief cells. In testing for folate deficiency, measurement of erythrocyte and serum folate levels are performed following the CBC. For non-megaloblastic anemia, reticulocyte count can help distinguish between causes where the bone marrow is not working well, such as alcohol use or hypothyroidism, and causes like hemolysis or hemorrhages. Reticulocyte count will be high in hemolysis or hemorrhage and will be low in alcohol use or hypothyroidism. Treatment involves finding the underlying cause and correcting it, as well as supplementing with intramuscular vitamin B12 injections and oral folate in cases of deficiencies.